Hello, good morning. My name is Wei Lee. I am a fellow in female pelvic medicine and reconstructive surgery at Virginia Mason in Seattle. I am happy to introduce Dr. Una Lee, who is one of the authors for the AUA and SUFU recurrent urinary tract infection in women guidelines. And she is currently faculty here at Virginia Mason in Seattle. She did her residency in Cleveland Clinic and her fellowship at UCLA. And take it away, Una.
Good morning, everyone. Thank you, Wei. This is a topic that's near and dear to my heart, partly because it's something that all providers, urologists, we see often. It causes, it's common in women, it causes a lot of distress, and we can really meet their needs. The guidelines were released in 2019 and really provided a lot of evidence and guidance to guide this. So here are my disclosures. We have 3 learning objectives this morning. We're going to review the guidelines on recurrent uncomplicated urinary tract infections in women. We're going to summarize the evidence underlying these guidelines as well as important principles and concepts. And we're going to do a couple case discussions to highlight these principles. So as you know, UTIs are prevalent, costly, and burdensome. 60% of women will experience an acute UTI in their lifetime. And of these, 20 to 40% will have an additional episode, of which a great proportion will have multiple recurrent episodes of UTIs. The evaluation of treatment of UTIs costs $2 billion a year in the US, and there's been significant growth of antibiotic resistance in the past 20 years. Interestingly, non-adherence to guidelines for treatment of acute UTI is more common in patients with recurrent UTI. So they're going off the path. There's been a shift in understanding of urine. Urine is not sterile. The microbes reside within the urinary tract, even in immunocompetent competent hosts without symptoms, and these organisms are symbiotic with their healthy hosts. So antibiotic stewardship is the coordinated intervention designed to improve and measure the appropriate use of antimicrobial agents. It involves the selection of the optimal regimen, the appropriate medication, dose, duration, and route, in order to achieve the best clinical outcome while decreasing toxicity and selective pressure. Another important principle is that it should reduce excessive cost. So unnecessary antibiotic use is a thrust of the CDC, as 56% of all inpatients receive at least 1 antibiotic, and approximately 30% of these may be unnecessary. 60% of antibiotics are given to outpatients, and 12% of all office visits end up with an antibiotic script, of which up to 50% may be an inappropriate treatment of asymptomatic bacteriuria. Antibiotics are 6 of the top 25 drugs for cost and 10% of total inpatient drug budgets. So collateral damage is a theme of the AUA guidelines. And what this is that antibiotics are associated with collateral damage. There are ecological adverse events associated with antibiotic use and misuse. It selects for drug-resistant organisms. There's unwanted development of colonization or infection of unwanted organisms. The most common and potentially devastating would be Clostridium difficile. There's some new national estimates published in the CDC in 2019 about the antibiotic resistance threat report. 2 million infections a year caused by antibiotic-resistant bacteria and fungi, up to 35,000 deaths, and C. difficile is related to antibiotic use and antibiotic resistance in over 200,000 cases and 12,000 deaths. So this was an interesting article in Science in 2016 about the collateral damage relating to and being associated with a decline in microbiome diversity. This occurs on an individual level, a community level, a population level, and an ecological level. It can be rapid and it can be persistent. There are observational, clinical, and epidemiological studies that are showing antibiotic exposure is associated with an increased risk of disease pathogenesis. And they're even showing causal mechanisms now. Loss of species diversity leads to metabolic perturbations and immunological function. So this graph, the blue graph, is the decline in microbiome diversity in the US. This occurs with modernization and use of antibiotics. And what can we do to further stop this damage? So the AUA guidelines statement of need is that It's to decrease the risk of antibiotic resistance, reduce the antibiotic adverse effects of antibiotics, provide guidance on antibiotic and non-antibiotic prevention strategies, reduce the recurrence of UTI events, and improve clinical outcomes and quality of life for women with recurrent UTIs. The AUA Practice Guidelines Committee collaborated with the AUA, the Canadian Urologic Association, and SUFU, the Society of Urodynamics, Female Pelvic Medicine, and Urogenital Reconstruction, to perform a review of the literature and a consensus expert opinion to define evidence-based management of healthy women with recurrent UTIs, establish guidelines in the evaluation and management, and to evaluate these treatment and prevention interventions. So the study population is important to be focused on. The index patient in this case is an otherwise healthy adult female with uncomplicated recurrent UTIs. The UTI should be culture proven and associated with acute onset symptoms. And we do exclude certain categories of patients: pregnant women, immunocompromised, abnormal urinary tracts, neurogenic bladders, etc. And we're not discussing the UTI in the setting of procedures or operations. As far as defining UTIs, it's defined, it's a common definition, 2 episodes in a 6-month period or 3 episodes a year. And to be uncomplicated, you can have no anatomic or functional abnormalities of the urinary tract, no immune compromise, and no multi-drug resistant bacteria. So a systematic review is performed. There were criteria for inclusion and inclusion of studies. 75 studies were included. The data was extracted and the relative risks and confidence intervals were calculated. The risk of bias was assessed, and the data was synthesized with a rating of the body of evidence. So you've seen this before in other guidelines. These are the evidence strengths A, B, and C. The recommendations are either strong, moderate, conditional, clinical principle, or expert opinion. So clinicians should obtain a complete patient history and perform a pelvic examination in women presenting with recurrent UTIs. This is a clinical principle. When you take a history, it should be targeted at risk factors, including life events, their sexual activity, history of pelvic surgery, menopausal estrogen decline, fecal incontinence or diarrhea, and antibiotic use. You also need to take into account health conditions such as immunosuppression, diabetes, and neurologic conditions. In taking the history, it's important to assess for opportunities to educate. So inquire about their current prevention strategies, including reassurance about self-blame, assess their water intake, and what symptoms do the patients attribute to their UTIs. It's an opportunity to educate them that what a UTI is versus what a UTI may not be. The hallmark of acute UTI is acute onset dysuria, frequency, urgency, and suprapubic pain. Patients often attribute odor and cloudy urine to a UTI, and that's not limited to, it's important to educate them that you can have an odor and cloudy urine in the absence of a UTI. It's not specific, is what I meant to say. There also can be the issue of fatigue and confusion in elderly patients. And again, this is not specific to UTI, but the whole clinical picture needs to be taken into account. These symptoms often overlap in patients with overactive bladder, pelvic pain, IC, and vaginal atrophy. And so it's important to tease apart these symptoms and figure out what's baseline, what's an exacerbation versus what's an acute episode of bacterial infection. So the physical exam should be part of a thorough evaluation. You need to screen for related findings such as vaginal atrophy or the GU syndrome of menopause. A urethrodiverticulum would be an important finding. That would be a fullness of the urethra with or without discharge. You may see evidence of fecal soiling, flank tenderness, and incomplete bladder emptying could be demonstrated on a PVR. There may be other incidental findings that you find in your evaluation, such as pelvic prolapse, vulvar skin conditions, urethral vaginal cyst, or pelvic masses. So to make a diagnosis of recurrent UTI, clinicians must document positive urine cultures associated with prior symptomatic episodes. So it's important that you establish the diagnosis of UTI with prior cultures. Review their cultures. If they're in your health record, you can review these if you need to obtain their outside records to do that. Because women lacking this microbial confirmation may be incorrectly treated for UTI when they should be evaluated for other conditions. Clinicians should obtain urinalysis, urine culture, and sensitivity with each symptomatic acute cystitis episode prior to initiating treatment. So each episode should be evaluated as a unique event, as non-adherence to guidelines is more common in women with recurrent UTI. Cystoscopy and upper tract imaging should not be routinely performed in the index patient presenting with their recurrent UTI. Studies have shown a low yield of anatomic abnormalities. However, in someone who's not responsive to appropriate treatment or if there's a clinical suspicion, it can be done based on clinical judgment. You may be looking for a urethral stricture or urinary tract obstruction, foreign body such as mesh, bladder stones, a fistula, a urethral diverticulum, or bladder pathology such as cancer. So to summarize the evaluation of recurrent UTIs according to the guidelines, you need a targeted history and physical to assess for risk factors, obtain a urine culture with each symptomatic episode, obtain a culture if persistent symptoms, obtain new specimen if the contamination is present. You do not need a test of cure or surveillance testing, and cystoscopy imaging should not be routinely performed but targeted at those with a high clinical suspicion. So there have been qualitative studies on women with recurrent UTIs, and there's a high level of distress and anxiety related to recurrent UTIs. They sometimes feel that something is seriously wrong with them, and they want to know what is causing this. This affects all aspects of their lives, emotionally, relationally, productivity-wise. There's often self-blame and guilt. They have a great deal of concern about antibiotic use and resistance. They sometimes see doctors as villains and heroes. They're desperate for a cause and a cure. They're interested in healing and alternative therapies. And one recent study showed they wanted to improve the acute UTI experience, whereas the doctors were focused on prevention. So something I use in my clinic is the 4 habits of patient-physician communication. And this is a course, and it's actually originally a Kaiser model, where you invest in the beginning. You're creating rapport, you're really listening to their concerns, you're sort of outlining the agenda for the visit. You elicit their perspective so that you can address their needs. You demonstrate empathy with your statements, like this must be very distressing for you, or I'm sure this has been hard. And then you invest in the end. You actually loop back and you provide the education, you make sure you've answered their questions, and you make a plan for moving forward. So how can we better meet patients' needs with evaluating women with recurrent UTIs? I think it's important to validate and acknowledge their experiences, specifically ask for what concerns and questions they have, and then answer in language that they can understand. Utilize the evidence and guidelines to educate and counsel them, and then create a mutually agreed upon plan for evaluating them and preventing. So we're moving on to treatment. Clinicians should use first-line therapy, NITROFURANTOIN, Bactrim, or FOSFOMYCIN, dependent on the local antibiogram for the treatment of symptomatic UTIs in women. So this is from the IDSA guidelines that were published in 2011, and this has been updated and is still current. These antibiotics were chosen specifically for their low rate of resistance, their low rate of collateral damage, their efficacy, and it's NITROFURANTOIN twice a day for 5 days, Bactrim once a day for 3 days, or twice a day for 3 days, or 1 dose of FOSFOMYCIN. The studies have shown these are effective in treating UTI while less likely to produce collateral damage. And you should know your local resistance pattern, and Bactrim not recommended for empiric use if the resistance exceeds 20%. Clinicians should treat recurrent UTIs in patients experiencing acute cystitis episodes with as short as duration as antibiotics as possible, generally no longer than 7 days. And in patients with recurrent UTIs experience acute episodes associated with urine cultures resistant to oral antibiotics, clinicians may treat culture-directed parenteral antibiotics for as short as duration as possible, generally no longer than 7 days. So for these women with resistances on their cultures, many of these organisms are called by ESBLs. Many are susceptible only to carbapenems. But before considering IV antibiotics, order FOSFOMYCIN susceptibility testing and check NITROFURANTOIN susceptibility. Many are susceptible to these agents, and so you have to specifically ask usually for the FOSFOMYCIN testing. You also may want to consult with your infectious disease specialist in these cases. So following the discussion of the risk benefits alternatives, clinicians may prescribe antibiotic prophylaxis to decrease the risk of future UTIs of women of all ages previously diagnosed with UTIs. So these are these dosages and agents are derived from the clinical trials that have studied this, either daily prophylaxis or pericoital prophylaxis. You can see the list here. It's single-strength Bactrim, double-strength Bactrim, NITROFURANTOIN, 50 milligrams or 100 milligrams, cephalexin at low dose or at 250 milligrams daily, or phosphomycin 3 grams every 10 days. Trimethoprim 100 milligrams is listed there, but it has been shown to have some little less efficacy. For pericoital prophylaxis, again, you have single-strength Bactrim, double-strength Bactrim, NITROFURANTOIN at either 50 or 100 milligram dose, and cephalexin. Okay. So the systematic review for this guideline identified 28 trials evaluating antibiotics for the prevention of UTI, or recurrent UTI. One of the trials was published comparing NITROFURANTOIN and phosphomycin in 2007, but all the other trials were published in or before 1995. So these are old data, but they still kind of create our standard of care. And quinolones were studied back then as prophylaxis, but given the risks associated with ciprofloxacin, its use is not recommended for prophylaxis. Most were rated at medium to high risk of bias, mostly because they did not report the factors used in the assessment of bias and because these are older studies. Results do consistently demonstrate the positive effect of prophylactic antibiotics. They are effective. And then you do have to acknowledge a mild increase, mild, moderate, or severe increase in adverse events, usually GI or vaginitis. So NITROFURANTOIN. It's commonly prescribed in women of all ages. There are rare but possibly serious risks of pulmonary hepatic toxicity. When you review the literature, these events are exceedingly rare, 0.001 to 0.003%. Really the risk would be in someone with underlying lung condition, and so you can avoid NITROFURANTOIN in these patients. You can reassure patients that it is safe to take, and you could screen them with an oxygen level, periodically. It does seem like chest X-rays often would be too much, but an occasional chest X-ray would probably screen them for the pulmonary fibrosis that's at risk. There also is a risk of NITROFURANTOIN in older adults. The 2015 Beers update has been modified to recommend avoidance of NITROFURANTOIN when creatinine clearance is below 30 milliliters a minute. So keep that in mind in the older adults. So asymptomatic bacteria should not be treated in patients with recurrent UTI. There's actually multiple studies, but one randomized clinical trial to show that women with a history of UTIs and ASB have found that antibiotic treatment was associated with an increased risk of symptomatic recurrence and development of antibiotic organisms. So it's found that actually asymptomatic bacteria can be protective of the host. So in summary, low-dose antibiotics for UTI prevention, the data supports efficacy and safety for low-dose antibiotics in decreasing the frequency of UTI. The majority of literature was published prior to 1995, and it's important to do shared decision-making. Patient goals balance with the risk of antibiotics and the known efficacy. So again, as a summary of recurrent UTI treatment, it's important to confirm the UTI with culture, treat per culture sensitivity, and utilize first-line antimicrobials as outlined by the IDSA guidelines. It's important not to treat asymptomatic bacteria and to educate patients on that so they understand why it's important not to treat that. Treating with short courses of antibiotics, and patient-initiated prophylaxis can be offered. It can either be daily, self-start, or pericoital, and reassessed in 3 to 6 months. This is found to be safe and effective, and you just need to counsel them on the potential risks. So this is the AUA guideline algorithm. We've gone over the history and physical, if suspicious of complicating factors, consideration of additional studies. We've reviewed antibiotic treatment. On the left bottom side, self-start therapy, episodic treatment, and oral antibiotic resistance. And now we're going to talk about prophylaxis that's non-antibiotic as well. So in the categories, the first category would be behavioral modification. There's been a lot of myths and confusion about this, but the evidence shows that frequency of urination, hygiene practices, hot tub use, pre and post-coital voiding, douching, and tampon use are not important, as the evidence does not support this. Certainly common sense is important, and but to not over stress patients out about this. Water intake, actually, there's level 1 data now to show that water intake is important. This was a randomized clinical trial of 140 premenopausal women with low water intake at baseline, and they were randomized to either no additional fluid or additional 1.5 liters of fluid. They were actually shipped bottles of Evian water, and this study was sponsored by that water company. The primary outcome was frequency of recurrent UTI with symptoms and microbial confirmation. It showed that the water group actually had fewer UTI recurrences, a mean of 1.7 versus 3.2 UTI episodes over a 12-month period, and this was statistically significant. The reduction was in the order of 40%. So this is a relatively straightforward intervention for women who you identify as having low water intake. We still don't know, for women who are hydrated or overhydrated, we don't know the benefit. So other behavioral modifications with some evidence. Eliminating or reducing spermicidal products and or barrier contraceptives have been shown to decrease risk of UTI, as well as if patients have signs or symptoms of dysfunctional voiding, pelvic floor PT over 12 months has been shown to also decrease episodes of UTI. Cranberry. It's important to understand about cranberry. You'll get a lot of questions about it, and it's important to know the data. So here's a summary of the data. The active bioavailable molecule is soluble proanthocyanidins. It's also called PAC or PACs. This inhibits FIMH binding to the urothelium. It's been demonstrated to have a dose-dependent effect on the UPEC adherence and inhibits the bacterial adhesion to the urothelium. And this photo is from this figure is from a publication on this. The A diagram is placebo, B is 18 milligrams of the PAC in urine cultured, E. coli cultured in urines after consumption of this. C is 36 milligrams and D is 72 milligrams. So these are people who consumed the cranberry powder containing this documented dosage of PACs, and then the E. coli was cultured in their urine. So it showed that the 36 to 72 milligrams was most effective. It's also important to know the difference between soluble PAC and insoluble PAC. So soluble PAC is from cranberry juice or juice-based extracts, powders, and supplements made from these juice extracts. This is the active ingredient that's going to have the most efficacy for antibacterial adhesion. The insoluble PACs are supplements made from seeds, skin, stems, pulp, and this cellulose and this pectin actually interferes with the anti-adhesion activity. Okay, so that's the active ingredient that's been isolated. In the guidelines, 8 randomized clinical trials were looked at, 5 were ultimately included in the meta-analysis. It did show that cranberry was associated with a decreased risk of experiencing at least 1 UTI recurrence compared to placebo or no cranberry. The limitations was that side effects were not often reported, and it's difficult to recommend one formulation over another. Overall, this is felt to be low risk intervention. And there's some more information on cranberry. So the confusing thing is that what's on the market are commercially available cranberry products in the form of supplements, and there's such a variability in the level of PAC. So you can see there's 7 tested here by an external lab, and only one of them really had the kind of potent and available level of PAC, whereas the other ones were on the order of, 1 to 4 milligrams. And the labeling is very confusing for patients, and you just don't know really what you're getting. And so that's the difficulty in this food-based sort of supplement. And if you talk about juice, again, you don't know how much juice to recommend. You don't know if the juice, what the dosage of the juice is either. The supplements, at least you get a concentrated amount, but you have to get a high quality supplement. So I thought this article was very interesting and helpful to kind of sort out all the data. It looked, we know that cranberry has been used for, many years to prevent UTIs among healthy women, but the efficacy has been controversial because of conflicting conclusions in multiple meta-analysis over the years. And what they did was an analysis to show that it was a variability in the participants and the outcome measures that led to this confusion. So there's heterogeneity when you combine complicated and uncomplicated UTIs, as is done in this Jepson 2012 review. They're combining trials from women with recurrent UTIs, elderly women, children, pregnant women, neurogenic bladders, and patients with radiotherapy. Whereas this Wang study in 2012 weighted things differently and showed that there was actually efficacy when you look at the clinical trials assessing prevention of recurrent UTIs in generally healthy women. So it's the weighting of the studies when they do these meta-analysis, and it's kind of like, you know, so you have to really kind of tease through the data to kind of look at what your target population is and what your outcome measure is. And so for this guideline, we were looking at generally healthy women with recurrent UTIs as measured by culture positive UTIs. And when you look at that, cranberry there was some evidence, and so we could recommend that. But there's just still very limited data. So now we're going to talk about some other options, and unfortunately, there was very little evidence. There was very few randomized clinical trials. There were imprecise estimates, methodological shortcomings, so we could not recommend any of these other options for patients. The top of the list is lactobacillus probiotics, either vaginal or oral, and there is some compelling data that vaginal lactobacillus probiotics does have some efficacy, and this is available in Europe, but more data is needed. And certainly there is some biological plausibility. Methanamine, also called Hyprex, is an antiseptic. It hydrolyzes to ammonia and formaldehyde and is therefore bacteriostatic. This has been used for hundreds of years in urology, and it's an attractive non-antibiotic option. It's sort of getting a resurgent. It's broad spectrum, it has limited side effects, very little association with resistance. It's a 1 gram twice a day. Sometimes people do have, it's kind of acidic, but again, the data was very limited. There are 2 trials that were very old. There's one meta-analysis, Cochrane review. So there was not enough data to recommend it or really make a statement about it, but it is being used clinically. D-mannose is also very popular with patients, and they're always asking you about it. It inhibits the mechanism proposed is that it inhibits FIM-H epithelial cell adhesion and invasion. The data is just super limited. There's not enough to really make a statement about it. There are also supplements and herbs that patients will use, and again, limited data, likely no harm. Intravesical hyaluronic acid, again, limited data. And then the vaccine data is actually very promising, but not ready for prime time. So when we look at postmenopausal women, there's a prevailing theory that decreased epithelial glycogen leads to diminished lactobacilli, loss of the acidic environment, and then colonization with uropathogens. And based on this evidence, we were able to recommend vaginal estrogen to reduce the risk of future UTIs in peri and postmenopausal women. 4 RCTs were looked at with a mean age greater than 65, 313 women. Vaginal estrogen use was associated with a reduced risk of experiencing greater than 1 UTI versus placebo or no estrogen. There was a lack of clear superiority of one formulation of vaginal estrogen or another. These are the main formulations. They come in a suppository, a vaginal ring, or vaginal cream, and they're sort of equivalent low-dose vaginal estrogens. They should be distinguished from systemic estrogen, which is oral and designed to go throughout your body, whereas this is local and really designed to be in the sort of vaginal, vulvar, urethral bladder area. So we like to counsel patients on that. The risk in the insert will list all risk associated with estrogen, and so sometimes it scares women. So you just have to really educate them that this is a different product and a different risk profile. And then also important to consult with their oncologist if they have a history of breast cancer. It's generally considered safe, but it's important to coordinate that care. So the AUA guidelines evidence for non-antibiotic options, this is a summary. For behavioral modifications, important to increase water intake additional 1.5 liters in low water intake women. Avoid spermicidal products. Consider pelvic floor PT if dysfunctional voiding. If they're going to do cranberry, you might want to recommend a cranberry product with 36 milligrams of soluble PACs and explain the mechanism of action. And vaginal estrogen, also important for repleting this in peri and postmenopausal women. For the others, insufficient evidence is needed. And as residents out there, this is an area of just much needed research. So if you have ideas in this area, I would encourage you to pursue them. So we have some Wei Lee, do we want to do cases or do you want to do questions right now? Want to do some?
I think the cases would be.
Okay, let's do some cases and then we'll have a little time for questions. So, a 25, and by the way, if you do have questions, please put them in the chat and Wei will bring them up so we can discuss them as well. So this is a 25-year-old woman with recurrent UTIs. She describes acute dysuria that starts the day after sexual activity. She's generally healthy with no medical or surgical history. She's on oral contraceptive pills. She has a stressful job as a consultant. She's a non-smoker. On exam, she has a normal female genitalia, no urethral fullness or tenderness. And her prior urine cultures were reviewed, and she gets consistent E. coli UTIs with greater than 100,000 colony-forming units, and they're pan-sensitive. So what guidelines does this highlight? I think it highlights a few. The first one would be that you need to obtain a complete patient history and perform a physical exam in women presenting with recurrent UTIs. And to make the diagnosis, you must document their prior positive urine cultures and be associated with symptomatic episodes. Okay? So she says, you know what, I've been on so many antibiotics, I really want to avoid them. I just don't feel like they're healthy. Of course, I need them when I have a UTI, but what can we do now? So what guidelines-based recommendations can you make to her? Another thing we can do is you can respond in the chat and we can summarize your answers. I'll just give you a pause to think about it. Based on this case, what would you do? Wei, are you getting any responses?
So far, none.
Okay. Do you want to answer, Wei?
So one response was consider cranberry supplementation.
Okay. And what would you, how would you counsel her on cranberry, just so that you kind of guide her in the right direction?
There's currently no response, but you did make a very good point in making sure that the amount of PACs was up to par with cutoff 36 and also preference towards soluble.
Yeah. So what's going to happen in real life is patient's going to say, I get this huge bottle of cranberry at Costco, and you know, and on the bottle it doesn't say anything about that. And so it's a little, it's just kind of, it's confusing out there. They're going to say, it says I get 3,000 milligrams or something. And it doesn't really, it doesn't correlate. And so, you know, real life issues is that the supplements that have that labeling are more expensive because they're high quality and they're processed a certain way, where some other supplements are maybe processed a different way, and they may or may not be effective. And so I tend to let my patients make their choices and give them these recommendations and let them choose. But I do try to steer them in that direction if they can afford it and if they're motivated in that direction. But some of those supplements, like the Costco one, and those have been tested, and they're the ones with the low level of the PACs. So it depends on what they need, and maybe that's enough for prevention for them, or maybe they need something more. Other options for our young lady with recurrent UTIs. I'm going to chime in that unless there's something, Wei, anyone responding?
One response was considering post-coital antibiotics.
Exactly, yeah. I think that would be an option to give her you could even show her that algorithm and say, look, here are all your choices. Let's go over each one, and then we can guide that. Because the nice thing about post-coital is that it's a little bit more targeted, meaning it's not daily, but it's sort of targeted at the moment of vulnerability. And so it's a little less antibiotics. And so that might be something you should be interested in. You could also do post-coital cranberry. That's not on there, but that could be something.
There was just another response, which is one of my favorites, increase fluid intake.
Absolutely. So you want to assess her fluid intake. You want to say, how much water are you drinking? Get a sense of it. And if she has got low water intake, you can certainly say, you know, you need to increase it. And I usually say, drink 2 liters of water a day. You know, the data shows an increase of 1.5, but it's about the same. Okay, so that's not an easy, but it's a relatively straightforward intervention. And the mechanism of that is, are you flushing it? Are you diluting it? I mean, there's multiple potentials, but it's a doable and reasonable intervention. Another thing to assess for her would be, are you using spermicidal products, right? Are you, you know, is that, and then if so, eliminate those. These are kind of, each little thing can contribute. And so to ask and then follow up. All right, any other thoughts? Okay, so this is, she's choosing to maybe pursue cranberry. She's like, okay, I like that idea. I like that it's natural, and I will go with your recommendation and get the one that you recommend, or at least look for, you know, something that seems high quality. And maybe I'll take it after, maybe I'll take it daily, maybe I'll take it 2 after sexual activity, something like that. So 3 months later, so she does well, and then 3 months later, she comes in with acute onset dysuria, increased urgency frequency, suprapubic discomfort. What are the guidelines-based next steps?
Respondents suggest getting a urinalysis and culture.
Absolutely. So you can't just, like, you know, sometimes you just have to follow the regular algorithm for an acute UTI. So we're going to obtain a urinalysis, urine culture sensitivity for each symptomatic episode, and then we're going to use first-line therapy. Because she might say something like, oh, Cipro works for me, it always works, I want Cipro. And you say, well, we're going to go with this because it's effective and it has less side effects and it's more, you know, less likely to cause you know, other problems. And so as long as you explain it, you know, and if you start talking about the risks of Cipro, they'll certainly be like, oh, I don't want that. And they'll go with what you recommend. So her symptoms have resolved, but now she's interested in a little bit more aggressive approach. Okay, so you give her the options again, go over all the guidelines-based options, and following the discussion of the risk-benefit alternatives, you can then prescribe, in this case, offer her antibiotic prophylaxis, daily or pericoital. And if she chooses pericoital, Wei, what would we recommend in her case?
We have a lot of good options that are fairly non-toxic. We can do single dose Bactrim, NITROFURANTOIN, or Calflex.
Yep, I think all those are reasonable. My go-to would probably be NITROFURANTOIN 100 milligrams postcoitally, just because it concentrates well in the urine, and then you save some of those other options for treatment. But you know, they're all studied and considered safe. If she's going to go daily, then again, you have all these options as well. And for someone who you would want to go with daily, might be someone who doesn't really associate it with sexual activity, someone who's just like, it just happens and there's nothing that triggers it, or maybe they're not sexually active, and then you would, you know, you could maybe steer them in that direction. All right, case 2. 75-year-old woman with recurrent UTIs. She also has genital discomfort, irritation, and at baseline, she has urgency frequency and urgency incontinence, and sometimes dysuria between UTIs that's mild. She has hypertension, osteoarthritis, and history of breast cancer. On exam, she has pale vulvar tissues, resorption of the labia minora, and erythematous vestibular and vaginal tissues. She's tender, atrophic. So what are you going to recommend?
There was a recommendation of estrogen.
Excellent.
Estrogen.
So in peri and postmenopause, oops, screen sharing is paused. Can you still see my screen?
Yes.
Okay. In peri and postmenopausal women with recurrent UTIs, clinicians should recommend vaginal estrogen therapy to reduce the risk of future UTIs if there's no contraindication. Okay. The evidence on this is strong. It is considered low risk. Clinically and anecdotally, it's effective. So she returns reporting that her atrophic vaginitis symptoms have improved. But she also says, you know what, I had my annual check with my PCP and a urinalysis was collected. Here's what it showed, 50,000 coliform units of Klebsiella. What do you ask her? Any thoughts? I'm giving you
a respondent suggested that we should check for any symptoms. Absolutely.
So you want to screen her for symptoms, and you know what? Someone like her has symptoms all the time. She has vaginal atrophy symptoms. She has OAB symptoms. She has a little bit of sort of discomfort symptoms. But what I like to ask is, do you have distinct UTI symptoms above and beyond your normal baseline? Like, is it, and I just assess the severity of it. Is it moderate? Is it mild? And it's important to assess these symptoms in different sort of buckets, give a sense of the severity, and also give her a sense of, you know, part of it is if we treat every time you have a mild increase, you're going to be on antibiotics all the time, and I'm concerned about side effects. And so can we treat this with supportive care measures, you know, and explain what asymptomatic bacteria is. Like, you live in harmony with good bacteria, bad bacteria, and usually this sounds to me, or this looks to me like good bacteria. And so I would recommend not treating this and just, you know, saying that this is just this is your normal flora that we're picking up here. And if you explain that, patients are very willing and accepting of not treating something like this. So this is the guideline. Clinicians should not treat asymptomatic bacteria. In this case, she was not symptomatic acutely. She had her sort of normal symptoms at that time. So in follow-up, she presents to the emergency room with chills, pain with urination, malaise, confusion. She's treated with Zosyn and IV fluids and admitted for UTI and dehydration. 2 days later, the urine culture shows 100,000 ESBL. She's treated for culture sensitivity and discharged on oral antibiotics. And she does return to baseline. So then she follows up with you in your clinic, telling you this story. What do you want to do? Any thoughts?
There was a suggestion of doing a renal bladder ultrasound.
Okay. So in someone who's had like a urosepsis episode and some, you know, more severe sequelae, it's certainly reasonable to get to do some anatomic evaluation. You're looking for kidney stones, obstruction, you know, something that could be contributing. I think that's reasonable. I'm going to move ahead here just because of time, but, you know, really, you don't have to do anything, but I think you should present to her options, you know, supportive care measures, monitoring. When she's symptomatic, submit a urine culture. You could consider prevention, you know, knowing that she had an ESBL. You could consider, you know, support, you know, all the options are basically at her disposal at this point, and it's a sort of a shared decision-making time. I certainly would consider continuing her vaginal estrogen, partnering with her so that when she is symptomatic to submit a urine. If she was going to do prevention, you might want to do something that's NITROFURANTOIN or FOSFOMYCIN, since she had that ESBL recently. Yeah, a PVR, a renal ultrasound. Those really, you know, weren't as strongly recommended in the guidelines, but I think clinical, you know, judgment is always, you know, important, and I think that's reasonable. So she decides to continue vaginal estrogen, and then she wants a prophylactic antibiotic, fosfomycin, every 10 days, and she does well. I was going to have an alternative pathway for her, is that she gets C. diff and all this stuff, but you know, that's, you see these patients, they take so many different pathways, and you have to kind of take them as, you know, as they come. So in summary, I would encourage each of you to read the entire guidelines text. It's packed with good information, and so you have to know this data and the principles, and it's summarized well. There's a judicious, you know, it promotes the judicious use of antibiotics to decrease the risk of collateral damage. Urine culture should drive diagnosis and treatment. No treatment is needed for asymptomatic bacteriuria, and you should perform shared decision-making on prevention options and educate them and communicate well. All right, so it's time for questions. And this is the final slide for the COVID-19 lectures, and you can share your thoughts.
All right, thank you, Dr. Lee, for tackling a very pervasive and oftentimes challenging and disruptive part of the patient's course that many urologists will see. That was very engaging and interesting. Some questions that we have from the audience, and you can continue to submit as we present. The first question is your recommendations of using vaginal estrogen products in patients with history of gynecological cancer.
Absolutely. So vaginal estrogen products are considered low dose and not systemic, and so I would just coordinate with their oncologist. It depends on their history, how remote it is, you know, and their risk. But generally speaking, most, if not all, oncologists that I've worked with have been okay with vaginal, you know, a vaginal estrogen treatment. Some of them even, let's say they've had breast cancer on tamoxifen, they develop these symptoms and these problems, and then in coordination with them, we put them on a vaginal estrogen, knowing that they have this history. But gynecologic cancers as well, I think as long as it's coordinated and sort of cleared, you know, sometimes patients have that anxiety about it, but with the proper education and collaboration, I think it's a very reasonable option.
Another question was, during the process of writing the guidelines, did you encounter any data or consider recommendations towards the use of intravesical therapy?
Yes, that's a very good question. So clinically, we see that people get gentamicin installations, bacitracin installations, acetic acid installations. There just wasn't, you know, the level of data needed to get into the guidelines, or, you know, we're kind of, you know, it was level 1, you know, RCT data. And so there was just not enough data to recommend something like that. And so again, more information is needed, more research is needed to sort of bolster these, whether it's effective. Certainly it does avoid the side effects of an oral medication, but how efficacious is it? These are usually people who have catheters or self-cath, so they can get that into their system. I guess sometimes people have them come into the office to get it. It's usually sort of, you know, refractory people where people are just trying anything. But certainly it's done clinically, just the evidence is just not all there yet.
And do you have any recommendations towards treatment of patients with chronic kidney disease, specifically using methanamine or fosfomycin?
Yes, I would coordinate with your pharmacist to calculate their renal dosing and whether this is allowable. It just depends. I think, you know, you could either do a renal dosing of the medication, or, you know, look for alternatives, but there's usually something that could work.
Okay, and how do you manage the usage of vaginal estrogen in patients who don't have optimal insurance coverage?
That's an issue too. All of these things are driven by insurance coverage, and vaginal estrogen tends to be expensive. The pricing and the cost has gone down over the years, as there are some sort of generic options. And so I try to partner with the patients and say, for example, some of these creams may last them 3 months. And so I know this cream's expensive, it may be $80 or $100, but if it lasts you 3 months, it might be worth it to you, you know, if you kind of take the cost of that. Usually one of the formulations will be covered by their insurance in some capacity. not all, but it'll either be the cream or the suppository or the ring. Usually it's the cream or suppository is covered. And there are some like companies now that are seeing this need and offering sort of lower cost options and coupons and things to patients from their website. And so I think with some creativity, patients can definitely get this.
Do you have any experience using compounding pharmacies?
Yes, actually I should have mentioned that too. Sometimes you can get it compounded at a lower rate, or patients like the idea of a compounding. Sometimes they have some like sensitivities to the cream that's used. What is it called? Not the barrier, but the vessel that is put in, and so you can get a very like hypoallergenic version of it. And so yes, I do use compounding pharmacies for that, for either patient preference reasons or sometimes cost reasons, because you can it can be a cheaper cost depending. So yeah, absolutely, you can do that.
And you had mentioned in your discussion that there's evidence that asymptomatic bacteria could be protective in the context of recurrent urinary tract infections. Mm-hmm. Do you feel that it should still be treated in complicated patients, such as those with poorly controlled diabetes or neurogenic bladders?
Mm-hmm. Good question. Yeah, so the data shows that in pregnant women, we should, because of the risks associated with that. In perioperative patients, because of the, that we're in the urinary tract. It depends on the other populations that we're looking at, right? Because if we treat it in every patient with catheter, or indwelling or, intermittent catheterization, that would be a lot of treatment. If we treat it in every patient with immunocompromised diabetes, that would be a lot of treatment. And so I think it's sort of on a case-by-case basis. It's a tricky situation. I mean, we're kind of delving into the realm of complicated UTI. And I think, again, more information is needed onto what is clinically meaningful and valuable and, improving them versus harming them.
And then there's one more question on your recommendations for management in the patient with atypical bacteria urinary tract infections.
Mm-hmm. Are you talking about, do you think they're talking about uroplasma, mycoplasma, or something else?
I think that's what they're referring to.
Yeah. That's a good question. It's not covered in the guidelines. We did cover PCR testing, because that's kind of out there right now, like more, advanced testing. And, it's a big unknown right now. What's clinically meaningful on some of those testing? Are we just getting a printout of their microbiome, and is it pathologic or not pathologic? So I don't think we really know about that area yet. That's that sort of the advanced testing. As far as atypicals, the data is kind of mixed out there as well. Some people thought that it would be very beneficial to treat these test for it and treat it, and some people think that it's, colonization and not that beneficial. So I think you'll run across different urologists who feel strongly one way or the other. I happen to be in the other camp where I feel like if they want to have one empiric treatment of it, that's fine, but I just don't feel like it's the cause of these symptoms, usually. Any other questions?
One question just popped up is, could you comment on candidiuria? And do you consider that really a urinary tract infection in a non-immunocompromised patient?
Candidiuria, yeah. So, yeah, I mean, that's definitely, it could either be a contaminant from the vaginal area, or it could be a real infection, and that's that has to be determined. Going back to our question about bladder irrigation, there is some data to show that antifungals and the locally irrigated may have a role in people with fungal presence in their bladder, but it's hard to know. I think the data is out there showing that we should treat that in the fungus in the urinary tract. But again, it depends on their clinical symptomatology and the clinical suspicion judgment.
All right, that looks like that addresses all of our questions, and we're out of time.
Yeah.
So again, thank you, Dr. Lee. That was very engaging and I think very helpful for our viewers.
Thank you everyone for tuning in, and I hope you learned something about recurrent UTIs and continue to read about it, think about it, and help patients with it. Okay, take care.